Thank you. It's a pleasure to be invited here and to give you sort of a background to left atrial appendage occlusion. I'm going to divide my talk into three major components. I'm briefly going to touch on development, or where these appendages come from. I think it's interesting, but also it may give us some clues as to why we actually have them. Talk about the overall form of the left atrial appendages, certainly in terms of the surrounding structures, surrounding cardiac structures that might be relevant to occlusion, and then focus mainly on some landmarks that are important if you are intending to perform intervention on the left atrial appendage. So if you look at all the textbooks, the left atrial appendage, the appendages and the atriums, these diagrams specify that the atriums are delineated from the outset, really, of the development of the heart. And here you can see the cardiac crescent with the atrium shown in pink at the base. And we now know this is not how it happens. This is a kind of simplified version. This compartmentalized scheme is actually a simplified version of how the chambers develop. In fact, as we're in Amsterdam, most of the work that has been put forward on how the appendages and atriums developed has been proposed by Anton Moorman and his group in the AMC, very close by. And they've really promoted the concept that the appendages and the chambers differentiate locally from this main cardiac, primary cardiac tube. So what you see here in this diagram is the initial cardiac tube, the cardiac crescent, if you like, in gray. And the chambers, we now know, balloon out from that structure at a slightly later stage, as I say, by local differentiation of the myocardium. And this concept seems to fit across different species, as well as in the human. Now, if we look at the evidence for that, this is, in fact, the first appearances of atrial natriuretic factor, factor and peptide within the atrial and ventricular components of the heart. We're looking here at a mouse embryo, in fact, and the purple stain is atrial natriuretic factor. And you can see that at an early stage, there's very little stain, but literally one day later, we've now got marked expression of factor within the ventricles and beginning in the atriums. And if you look at this and a whole series of other molecules, we can see that, in fact, what's happening is the atriums and ventricles are expanding or ballooning out from an initially primitive heart tube. So the importance of that is that the appendages, as you can see on the left-hand side, actually balloon out to the right and the left side of the embryo, and that they are therefore under the influence of any factors which determine laterality within the embryo. And in contrast, the ventricles will balloon out in an anterior-posterior axis, and therefore are less influenced by laterality. And we now know that there are several genes, there are many genes, in fact, which are expressed exclusively on the left or the right of the embryo. And these are some of the genes, nodal, lefty, and PITX2, which will affect development of the atrial appendages. The appendages themselves begin their characteristic shape very early in development, so we can see them as characteristic structures from 8 weeks development, and here you can see at 10 weeks. And important really to recognize that they form a much larger proportion of the overall cardiac mass early in fetal life, so particularly in the first trimester of pregnancy. So I think they're able to act probably as a reservoir. They may also have a function in regulating blood volume early in fetal life. And of course, this then changes later in life. So in terms of development, we know that things are established very early on. the appendages are affected by laterality and that they differentiate from the primary myocardium, forming a large proportion of the heart in fetal life. So what we end up with in the fully formed heart is two distinct appendages. And here I'm showing you, first of all, the right appendage. I know we're not talking about the right appendage today, but you see that it's a very distinct structure, essentially triangular in shape, with this array of pectinate muscles on the inside, internal aspect, which extend all the way around the tricuspid valve to the inferior part of the right atrium. So for us, that's the characteristic feature of a right atrium, is this large pectinated portion, well, in fact, the fact that the appendage is, in fact, a relatively large structure. If we compare that to the left side, here we see the left appendage, and there are pectinate muscles within the left appendage, as you know well, but most of the left atrial wall will, in fact, be smooth myocardium, or should be smooth myocardium. So here you can see the pectinate muscles within the tip of the appendage, but most of the time they stop at the junction of the appendage with the remainder of the left atrium. So there are characteristic features in the fully formed appendages between the right and the left-hand sides of the heart. So generally, we talk about the left atrial appendage as being finger-like or tubular or being lobar in structure. We know well that it has a narrow neck with the remainder of the atrium, and it does contain pectinate muscles which are interspersed with a very thin, or usually thin, left myocardial wall. Just thought I'd mention that the pectinate muscles also contain AMP granules. Although I'm not going to talk too much about this, the pectinate muscles are the strands that contain the AMP granules, and these, of course, can be released in the setting of dilation. So, looking at the overall structure of the appendage then, this is a cast of the internal aspect of the left atrium, and you can see that it does look, has a finger-like structure. And the finger-like structure is partly determined by the lobar nature of the appendage, but also by the division of the lobes by these muscle bundles, which would fill these spaces here, which are the pectinate muscles. So that gives us this sort of coral-like appearance of the left atrial appendage. And in fact, I think in many ways it's the interaction between the lobar structure and the pectinate muscles which is important to understand if we're going to understand which pockets or which lobes to close during appendage closure. In this example, I'm showing you the appendage from the base of the heart. We've cut away the atrial chambers and the great arteries. And you can see the lobes here extending out onto the ventricular surface of the heart. And then if you look inside the appendage, you can see that the lobes are actually divided by the pectinate muscles, by these bars of muscles, into further pockets. So there's a lobar structure, but then there's further division into additional channels. Here you can see the smooth left atrial wall, more inferiorly, and we're looking at the coronary sinus there from beneath. If we transilluminate the left atrial appendage, you can see how thin the wall can be in between those pectinate muscle bands. So we're looking now at the os of the left atrial appendage. I'm shining a light from the outside, as you can see, and certainly the wall here between the pectinate muscles can be paper thin. That can be changed by disease. The appendage can be fibrotic and thickened. But certainly in the native state, the wall between the pectinate muscles can be translucent. So I think that's an important thing just to remember. If you look at that histologically, then you can see the pectinate muscle bands here and the left atrial myocardium in between those bands is only a fraction of a millimeter in thickness. And as I say, it's these muscle bundles here which contain the AMP granules, which are which can be secreted during life. Let's look at the relationship of the appendage then to surrounding structures. This can be an important issue when we're talking about appendage occlusion. The neck of the atrial appendage, or the os, which is effectively the origin of the atrial appendage itself, is effectively wedged between the mitral valve and the left pulmonary veins. And in between the left pulmonary veins and the os, you'll often find a ridge, a so-called posterior or pulmonary ridge. The course of the left atrial appendage then usually runs around the anterior surface of the heart, and the body itself will run over two important structures, the circumflex coronary and the great cardiac vein. So they can be at risk, potentially, with occlusion. As I say, usually the body curves around the left side of the pulmonary trunk, but will be separated from it by the transverse sinus, and the lobes run parallel to the margin of the left ventricle. So this is an intact specimen. This is, in fact, a pediatric specimen, which wasn't suitable for transplantation. And you can see the appendage, the left atrial appendage here, lying just to the left side of this structure, which is the pulmonary trunk. And there's a narrow space between the two, which is the left side of the transverse sinus. Now, the appendage itself has a lobar structure. You can see the lobes and the main course of the appendage lying flat against the obtuse margin of the left ventricle. Here you can see there's perhaps multiple lobes within this appendage, which is a pretty typical arrangement. And there's the kind of narrow neck with the pulmonary venous component. So the appendage itself usually wraps itself around the left side of the pulmonary trunk, as I say, separated by the transverse sinus. Now on the other side, you'll see the pulmonary veins. Here are the left pulmonary veins, the left superior and inferior pulmonary veins. And you'll appreciate there's a distinct fold between the pulmonary veins and the appendage itself. And this is what gives rise to the pulmonary ridge, which you can see when you're looking at these with CT, for instance, or on echo. Here's the back wall of the left atrium, separating the left from the right pulmonary vein. So this space is, in fact, the oblique sinus of the left atrium. Here's another example showing you the appendage, slightly more curved appendage this time, showing you some of the variation. And in this case, we've taken away the epicardial surface of the left heart. So we've peeled away the epicardium and the fat to show you the course of the left coronary artery and the left circumflex coronary artery. And you can see how that runs immediately beneath the neck, the narrow neck of the appendage, or the os of the appendage. Obviously, there will be some variation in that anatomy. This is a particularly large left circumflex. This is a left dominant coronary pattern. But usually that relationship is fairly consistent amongst hearts. Here's another example, again with a fairly sort of lobar left atrial appendage. As you can see, it takes the form of a concertina, which can be expanded and contracted. And what we've done in this case is just taken a section just above the mitral valve at the left atrioventricular junction. So this is septal myocardium, and this is effectively the annulus, if you like, of the mitral valve. And just above that level, you can see a small vessel, which is, again, running directly beneath the neck of the left atrial appendage. And this, in fact, is the great cardiac vein. You can see it's a thin-walled structure, and beneath there is, in fact, the circumflex coronary artery. So both of those vessels run very close to the opening or the neck of the left atrial appendage. So let's just focus on a few more landmarks which are specific for interventional device design, in particular the neck, the lobes, and the pectinate muscles within the appendage. And I'll show you some examples of some abnormalities. So the os, of course, is a crucial feature if you're talking about left atrial appendage occlusion. And we're looking here directly at the os. Here you can see the pulmonary ridge, more posteriorly, which is separating the os from the superior and the inferior left pulmonary veins. And on this side, we've got the left atrioventricular junction giving rise to the mitral valve. So the os itself is wedged, if you like, in this triangle of tissue between those two structures. And you'll see that it, in fact, is oval-shaped and is obliquely orientated with respect both to the ridge and to the mitral valve itself. So not an easy structure, not an easy thing to analyze and to measure its true diameter. In relationship to the atrial septum, here you can see the position of the atrial septum. We're transilluminating it from the right-hand side, and you'll appreciate how a septal puncture, in this case, I think would be fairly straightforward. Through the mid-portion of the septum would lead almost directly into the left atrial appendage. But of course, those relationships can vary slightly amongst patients. So the variations that you might see in the os are the size, clearly, the shape, which we've said is usually oval and oblique. The proximity of the os to the mitral valve and the left pulmonary veins can vary very slightly. I'll show you some examples of that. But also important to recognize whether or not there are additional pockets or openings or lobes, if you like, next to the true os of the appendage. And this, I think, is a very nice paper, a fairly recent paper, which shows CT analysis of the left atrial appendage, and in particular, the height of the appendage within the left atrium. So you can see in this first panel, the appendage is relatively high up within the atrium, so it's almost opposite the origin of the left superior pulmonary vein. In this case, it's slightly lower, so sort of mid in between the pulmonary veins, and in this example, it really approximates the origin of the left inferior pulmonary vein and is therefore, I think, closer also to the mitral valve. So there is variation in the actual position of the appendage relative to the height of the atrium and to the origin of the left pulmonary veins. Showing you some examples of that. Here's a relatively large atrial appendage. We're looking at it from the left-hand side. Here's the pulmonary venous component. And if we open out the appendage, you can see that the orifice of the appendage, or the neck, is in fact opposite the origin of the left superior and inferior pulmonary vein. So this is a typical origin of the opening of the left atrial appendage. So it's an obliquely situated opening, and this one is within the mid sort of upper region of the atrium. And there's a good margin here between the appendage and the mitral valve itself. In this cast of a left atrium, you can see the appendage is situated much more superiorly. So we've got this unusual sort of angulation of the appendage, but if you look at the opening of the appendage, it's almost above the origin here of the left pulmonary veins. There's in fact a common left pulmonary vein in this case, but you can see how high the opening of the appendage can be relative to the pulmonary veins and the rest of the left atrium. And this may be much more difficult, therefore, to approach from a standard transseptal puncture because of its superior position. Just a couple of other examples. Here is, again, an oval-shaped os, quite a large opening, I guess, in the setting of a prosthetic mitral valve. So I guess this opening is, in fact, if anything, lower. The os is lower than the previous examples that I've shown you. And you can see that, in fact, it's quite close to the prosthetic, the ring of the prosthetic mitral valve. It's relatively close to the vestibule of the mitral valve. And I think there is a relationship between the position of the os relative to the superior pulmonary vein versus the position relative to the mitral valve. there's a inverse correlation between the two. And then finally, an example to show you a pouch or a lobar, an additional kind of lobe close to the os. Here you can see a relatively low positioned appendage. It's very close to again, the sewing ring of a prosthetic mitral valve, which was taken away. And you can see that there's one main oval shaped orifice here. But then if you look more carefully, you'll see next to that, there's an additional, quite a significant additional pocket or lobe, and they're often positioned inferiorly within the atrium. So I think that would be difficult to exclude both parts of this opening, or to exclude the pocket as well as the main part of the appendage. Here's an example with significant pathology of the left atrium. You can see that the left atrium has thrombus within it, and the wall of the left atrium here is thickened with this very prominent fibrous lining. And I'm showing it to you really to show you complete occlusion, natural occlusion, if you like, of the os of the left atrial appendage. So thrombus here is filling the left atrial appendage, completely occluding it, and obviously that would be an important one to exclude. So finally, to finish with, just to talk about lobes and the pectinate muscles, there's a lot of literature on counting the number of lobes and looking at their morphology. The morphology is incredibly variable, but of course, I think it's important to recognize how close, particularly the lobes, are to the os of the left atrial appendage, and also the relationship of the lobes to any prominent pectinate muscles. So probably the easiest classification is simply to divide them into single or multiple lobes. I'm not sure we need to go any more complicated than that. If you look at pathological series, then which are sort of divided up into in slightly different manner, most patients will have 2 or more lobes, as you'll appreciate from here. So I'm not sure how useful that is. I think it is useful knowing the overall shape of the appendage and how that might fit with a device. Here's some simple variations. So a straightforward appendage, I don't think anybody would have problems putting a device in this one or closing this one. It's a single kind of lobe, fairly straight direction. The second one, of course, is a much longer appendage. It's wrapping itself around completely around the front of the pulmonary trunk. I'm not sure whether that was going to give you any problems with closure or not. Certainly, there's significant substance to the appendage. The third one shows a kind of horseshoe-shaped appendage hooked back on itself, and certainly that may restrict the amount, the sort of space here with which you could put a device. And then finally, a multi-lobed appendage here with lots of sort of additional strands or lobes coming from the anterior surface of the appendage. So lots of variations that you can find. I think probably the most important one to recognize is where there are 2 or so lobes and there are prominent muscle bundles within the appendage. So here you can see perhaps 2 major lobes here to this appendage, and this one is certainly very close to the os. When you look inside and look at the opening, you'll see associated with that we've got a prominent muscle bar, which is effectively narrowing the space here where you might place a device. So I think this sort of divided or this bifurcating appendage perhaps is a particularly important one to look at. And then just to look at the pectinate muscles themselves, this is again a fairly good size appendage. You can see the os is fairly well demarcated. Here again are the pulmonary veins with the pulmonary ridge separating the os from the pulmonary veins and the mitral valve on this side. And in this case, the appendage itself is particularly large and slightly thick-walled. And what I wanted to show this to you for is to show you how the pectinate muscles can actually could anchor a device, but also potentially anchor thrombus within the appendage. So here you can see a thrombus which is anchored within the pectinate muscles, and a much larger thrombus there within the tip of the appendage, anchored and stuck in between the strands of the pectinate muscles themselves. So in summary, I do think it's important to look at the structure in detail. I think we do need to have knowledge of surrounding structures, of the overall position and morphology of the left atrial appendage in terms of its os and the lobes, to be able to assess whether and which device we can place within these appendages. There are rarer variables, which I've shown you already, such as pouches proximal to the os and divisions with the appendage. I think they are rare, but I think it's important to know about them just in case, and so that you can adapt your occlusion to the morphology. Thank you.
Very nice, thank you. No, so it was a very nice movie. It was true.